We are there at our last couple PowerPoint slides and last video. So this is obviously week 15. We're finishing up with pain management and fundamentals of pharmacology for OT. So pain management. Pain control assessment, intervention, and pain management is the top priority in the acute care hospital setting. Pain control is a basic human right, and as healthcare professionals, we are obligated to not only address, but eliminate barriers to pain management. Throughout a hospitalization, pain should be assessed and managed, and screenings and education should be provided throughout that hospital stay. Pain is a distressing sensation or feeling caused by trauma or injury and is a top priority for all healthcare professionals and associations because of the high amount of pain that is reported while hospitalized, particularly for patients who have just undergone surgery. The three most commonly reported pains are back pain, headache and migraine pain, and neck pain. Acute and chronic pain can adversely affect appetite, sleep, energy levels, mood, cognition, quality of life, and mortality. Inadequate pain control is associated with poor physiological and immunological outcomes, increased incidence of hospital readmission, and increased access to hospital care. It can also lead to increased costs, increased disabilities, and reduced pain satisfaction. Just like we've been talking about from the beginning, pain must be addressed in every single occupational therapy session. Acute pain versus chronic pain. Acute pain is the sudden response usually associated with some kind of trauma and normally resolves as tissues heal. Chronic pain is uncontrolled, persistent, and progressive pain. It can be debilitating and impede full participation in rehabilitation. Chronic pain typically lasts more than 3 months with longer than expected healing time. Typically, opioids are utilized to manage pain. Effectively treating pain requires a coordinated interprofessional approach. And what this means is really we are communicating with the nurses on when pain medications are being administered, how quickly it'll get into the patient's system, and if it's not working, we're communicating with the nurses and the doctors to see if there's a different plan that can be implemented. Additionally, we can ask the primary team, for a referral for a pain management doctor to come in and see the patient to see if there's something different that they can work towards. It's really important that when we're managing pain to incorporate multiple strategies, including body-based, mind-based, and psychological pain management approaches. As a therapist, it's important that we work with the team to ensure we're finding balance so that the patients have adequate pain control while they're participating with us so they can achieve their highest functional level in mobility and self-care tasks, all while learning new skills. The goal, though, is to make sure that the patient is not over-medicated. If they are over-medicated, it could lead to lethargy, diminished alertness, confusion, and slowed recovery times. Pain classification. Pain is characterized according to the mechanism of injury. The types can be nociceptive, which is a result of tissue damage, or neuropathic, which is the result of nerve damage. Pain can also be classified as inflammatory. Functional, which is abnormal processing of normal input, and central sensitization syndromes. Say that one 3 times fast. Central sensitization syndromes describe how the central nervous system produces a pain response in the absence of a noxious stimulus. Maladaptive pain lacks a specific stimulus and does not promote healing. So there can be 2 types, nociceptive or neuropathic. Nociceptive pain is indicated by an acute injury that has occurred to the superficial or deep structures. The body responds to nerve injury and tissue damage through the CNS's stimulation of nociceptors, which serve as a warning of damage or threat. Examples of nociceptive pain include pain from surgery or trauma, burns, contact with acids or bases, or pain from ongoing progressive disease processes. Acute nociceptive pain is usually treated with oral analgesics. Neuropathic pain, however, involves damage or injury to the peripheral or central somatosensory nervous systems. Peripheral neuropathic pain symptoms may be the result of damage to small or large sensory fibers. Patients may complain of burning, stabbing, jabbing, decreased pain and temperature sensation, and decreased vibration and proprioceptive sense, as well as decreased balance, all of which can increase the likelihood of falls. Examples of peripheral neuropathic pain include diabetic neuropathy, carpal tunnel syndrome, and radiculopathy, as well as central neuropathic pain conditions, including the spinal cord injury, phantom limb pain, multiple sclerosis, and stroke. Acute pain assessment. So pain is classified by duration. Continuous pain is used to define pain that is present for at least half a day, while flare-up pain increases temporarily but generally is controlled at a baseline level of pain. Examples of pain may be widespread, which could be like fibromyalgia, or localized to a specific area of the body, such as the lumbar spine, the shoulder, etc. As an OT in the acute care setting, it's important to communicate with the hospital staff. I'm going to hit this home every single time. You've got to communicate with your team to figure out the best plan for your patient. So the therapist and the RN will communicate to identify the relevant pain issues. You're going to identify the current pain management protocols. The patient ranks their pain based on intensity. The patient and RN are asked when they got the last pain medication and if they need to be pre-medicated prior to therapy. And then also when the next pain medication is available. Based off of that, you can kind of find a sweet spot to see the patient, or if it's just not working out, be like, let's just try, see how you do today, and then we'll talk to your team to see if there's any other additional pain management therapies that they can incorporate. So as an occupational therapist, you can educate your patients that pain is temporary and a normal part of the healing. Engagement in ADLs can help to facilitate circulation and healing, and that pain does not necessarily mean that something is wrong. So patients who have had spine surgery, even if they're pre-medicated, there's going to be some level of pain, but we need to educate them and encourage them to move a little bit past it and see what they can do. Patients need to know explicitly that the therapist is there to help facilitate recovery. However, if the patient states this is too much, that the therapist will respect that and will formulate a new plan with the team, and therapy will be halted until that new plan is implemented. It's important to remember the psychosocial model that addresses early participation in activity, self-management, education, positioning, pressure reduction, and activity pacing. With this, we're going to focus on function and facilitation rather than necessarily alleviating all pain. So completing a pain assessment with patients that are nonverbal is a little bit different and can be difficult for some people. So when completing an assessment with nonverbal patients, you can try a self-report if possible. So have them shake their head yes and no if they're in pain, or show with their hands, or even write it out. You want to try to use a validated assessment tool such as the behavioral pain scale, the critical care pain observation tool, which we talked about in the beginning of the semester. If you need to, please go back and refer to those slides about what validated pain scales are available. These would also be good to use a validated pain scale in your final project. Additionally, it's important to search for the causes of pain, such as infection, invasive instrumentation, or musculoskeletal injuries when working with these patients. Lastly, use your clinical reasoning skills to observe behaviors that may indicate pain, such as rocking, grimacing, or bracing. It may be helpful to consider how environments can reduce their perception of pain. These considerations can include increased exposure to natural light, nature images, and sounds, as well as virtual reality and music for post-operative pain. Oral analgesics. Oral analgesics are typically typically prescribed for initial pain after surgery or trauma. Both over-the-counter medications and prescription medications are included in this. Over-the-counter medications can include acetaminophen, non-steroidal anti-inflammatory drugs, and aspirins. Opioids and morphines require a prescription from a doctor. They are used for treating short-term, severe, acute pain and cancer-related pain. However, it's important to monitor because high rates of addiction and overdoses are common with those two types of medication. Non-steroidal anti-inflammatory drugs, or NSAIDs, are used to address pain, reduce inflammation, and decrease fever. Examples of this will include ibuprofen and naproxen. Pain pharmacology. Adjuvant analgesics is when off-label pharmacology use is done in combination with other pain relievers. These can include tricyclic antidepressants to relieve neuropathic pain and improve sleep by influencing the amount of serotonin or norepinephrine present in the brain. Examples of this might include Cymbalta. Anti-anxiety medication and muscle relaxants help to reduce muscle spasms to address chronic pain and ultimately improve sleep and function. Examples of this might include diazepam, Flexeril, and Ativan. Anti-epileptic medicines can be used to treat neuropathic pain to suppress nerve signals that activate the pain pathway in the brain. Examples can include gabapentin and may be used to treat fibromyalgia, neuralgia, and diabetic neuropathy. Topical analgesics can be used for local or peripheral pain relief. These can include lidocaine in gel or cream form, ointment, or patches. Cannabinoids have been shown to be helpful in treating fibromyalgia, rheumatoid arthritis, diabetic neuropathy, and other types of neuropathy. Corticosteroids are administered through oral medication and injections and are typically used to treat bone pains, neuropathic pain, and visceral pain. So all those that I have mentioned in this slide, I will see very often in therapy sessions, and I will coordinate with the nurses based off of the amount of time it takes to hit the patient before I see the patient. I want the patients to be adequately pre-medicated based off of those medications. Non-oral and invasive pharmacological pain management. At times, more invasive pharmacological management is needed. These interventions can include non-oral pain medication management, including use of a PCA pump or pain-controlled analgesic, or implanted drug delivery systems, including epidurals, nerve blocks, and transdermal patches. With these, the medication is programmed for amount and timing of delivery. A PCA pump is typically used in post-operative situations. Epidural steroid injections are inflammatory steroids that are injected into the epidural space to reduce the amount of inflammation of nerve roots exiting the spine. Peripheral nerve blocks are used pre or post-operatively as analgesia to avoid systemic effects of opioids, address acute pain control, and provide treatment for neuralgic pain. Examples of this can include intercostal nerve blocks and stellate ganglion blocks. In the hospital, it is common to see the pain management team place a temporary femoral nerve block for a femoral shaft fracture. This is temporary, and there might be weight-bearing restrictions or precautions associated due to the fall risk as the nerve block wears off. Continuous peripheral nerve blocks are used for ongoing analgesic needs that typically last 3 to 5 days. These patients are seen by an orthopedic surgeon. Patients will have a portable infusion pump and catheter. In the chart, you may see this medication called bupivacaine. The team may recommend this pain pump to assist the patient with pain reduction, improved standing/toileting abilities, and improved quality of life. The implanted intrathecal drug delivery system, also known as a pain pump or spinal pump, is surgically implanted pump that delivers pain medication to the intrathecal space and around the spinal cord. So this is surgically inserted and is there permanently or semi-permanently until it needs to be taken out. That's for the intrathecal pump. Spinal cord stimulation is a minimally invasive procedure that blocks nociceptive pain, typically from chronic back or leg pain, using epidural electrodes at the spinal cord. A fentanyl transdermal system is a transdermal delivery system or a pain patch for fentanyl that is applied directly to the skin where it slowly is absorbed into the bloodstream. Occupational therapists can help to facilitate further engagement in occupational performance areas, skills, and patterns. Occupational therapists help patients and families by educating patients on pain pathways, pain cycles, and pain management techniques, which can help patients to gain a sense of control over pain and pain perception. Non-invasive treatments can include PAMS, chiropractic care, physical therapy, acupuncture, yoga, Tai Chi, biofeedback, relaxation therapy, hypnotherapy, mindfulness, and cognitive therapies. Chronic pain management strategies. Patients that have chronic pain will have deficits with work, self-care, leisure, and social roles. These patients are at risk for activity avoidance, deconditioning, and emotional/cognitive impairments. Therefore, occupational therapists should consider providing education, making environmental modifications, and reducing limitations to activity performance to facilitate leisure and recreation occupations. They can educate on high and low tech assistive devices, minimize discouragement, and facilitate engagement in occupation. Some long-term pain management techniques can include biofeedback, body mechanics, training, ergonomics, joint protection, relaxation techniques, and stress management. Other interventions can include use of portable pain control modalities, education of pacing of activities, and incorporating breaks into daily routines. Assertiveness training, training in anticipating and solving problems, and neuromuscular re-education that includes relaxation techniques. All should be used for chronic pain management strategies. Pain related to cancer can be due to the result of the tumor, radiation, chemotherapy, and surgical procedures. As an occupational therapist, it is important to collaborate with the patient and team to provide active listening and educate the patient to be an active decision maker about interventions and treatments. Education should be provided to minimize deconditioning, fatigue, and the development of preventable secondary conditions. Therapists can assist in incorporating experiential learning opportunities such as practicing relaxation and art. Pain management strategies. As a therapist, it is important to assist the patient in identifying meaningful role participation in areas of occupation receiving treatment for depression and actively accepting the possibility that pain will be a part of one's life. Physical agent modalities used in pain management can include TENS, NMES, ultrasound, thermotherapy, cryotherapy, and iontophoresis. Cognitive behavioral modifications used in pain management include biofeedback, hypnosis, imagery, and visualization, distraction, progressive muscle relaxation, and meditation. Examples of this can include listening to a book, listening to music, reading a book, praying, playing games, or watching a video. Visualization can include deep breathing and muscle relaxation. Body-based approaches used in pain management include exercise, range of motion, muscle conditioning, acupuncture and pressure, hydrotherapy, massage, mobilization, and manipulation, as well as Tai Chi and yoga. Chapter 12, Fundamentals of Pharmacology for Occupational Therapy. Pharmacology is a study of drugs and their origin, nature, properties, and effects on living organisms. The U.S. Department of Health and Human Services reports that at least half of all Americans take at least one prescription medication and that 1 in 6 Americans takes at least 3 or more. The use of prescription drugs is increasing among all age groups, and 5 out of 6 persons greater than or equal to 65 years old take 3 or more prescription medications. The risk for patients on multiple medications is that they are subject to drug interactions. Pharmacology basics. As an occupational therapist, practitioners may be able to improve therapy outcomes dramatically by scheduling sessions when drugs have reached their peak effect. Pharmacokinetics is the study of how medications are absorbed, distributed, metabolized, and eliminated by the body. Pharmacodynamics determines how and where in the body a medication elicits its actions and helps to describe the mechanism of an action at the cellular and organ system levels. Drugs have a variety of different names. Drugs can be identified according to their chemical, generic, or trade names. Pharmacological effects, medication routes. So as a therapist, it's helpful to understand distribution routes, rates, and routes of absorption, as well as drug elimination routes to anticipate the patient's response to medication. The amount of time it takes for a medication to reach its final drug compartment and receptor site determines how quickly it works. Enteral routes are routes of medication administered via the alimentary canal, oral, sublingual, buccal, and rectal. The most common administration is orally. If a tablet is swallowed, the drug is absorbed into the gastrointestinal tract and distributed to other parts of the body through the circulatory system. This will typically take 30 to 60 minutes after dosage. Enteric-coated medications have a protective outer layer that minimizes acid breakdown and allows the medication to pass intact into the small intestine for absorption there. Other enteral routes include rectal, sublingual, buccal, and transdermal. Enteral absorption is quicker than oral because the mucous membranes absorb the drugs directly into the bloodstream. Sublingual is under the tongue. Buccal administration allows the patient to suck on the medication, and rectal absorption is absorbed in 5 minutes. And it's typically helpful for patients with nausea or vomiting or for patients who cannot swallow. Parenteral routes are a method of administration that does not use the GI tract. Medications are given via injection, inhalation, topically, or transdermally. Medications are administered through IV, subcutaneously, or through intramuscular injection. Examples of this are antibiotics such as vancomycin. Absorption through an IV is typically 15 minutes. Transdermal medication bypasses the GI tract and is used in the form of cream, ointment, or patches. Examples include nitroglycerin patch or motion sickness patches and need to be replaced every 1 to 7 days. So on this slide, we're going to go through frequently encountered drug therapies that you'll see during your therapy sessions or in the patient chart. Hypertension is abnormally high blood pressure and was one of the most common diseases in the industrialized nations. Calcium channel blockers are used to treat hypertension by decreasing the entry of calcium into the vascular smooth muscle, causing relaxation and vasodilation. For congestive heart failure, the heart muscle weakens and leads to a buildup of fluid in the lungs and surrounding body tissues. Beta blockers are any class of drugs that prevent the stimulation of adrenic receptors responsible for increased cardiac action. Beta blockers are used to control heart rhythm, treat angina, and reduce high blood pressure. Medications used to treat hypertension and congestive heart failure include Bumex, Tenorim, Etripamil, Orlopressor, Labetalol, Cardizem, Benazidril, and Lisinopril. Multiple sclerosis is a chronic progressive disease involving damage to the sheaths of nerve cells in the brain and spinal cord. Baclofen is an oral medication that is used to treat spasticity associated with demyelination. Parkinson's disease is a progressive disorder of the nervous system that affects movement. Levodopa is an anti-Parkinsonian medication that improves rigidity and bradykinesia. Medications used to treat essential tremor, subcortical dementia, and Huntington's disease can include lorazepam or Ativan and baclofen. After hearing all those medications, you might think, what can I do? Why do I need to know this? How am I going to help patients? When really, those medications are prescribed by doctors. Really, though, occupational therapy has a unique role in helping these patients because prescription medication misuse is not taking medication as prescribed. It's estimated that between 20 and 50% of all patients do not take their medications as prescribed. Non-adherence to prescribed medications for those with chronic conditions results in poor treatment outcomes, increased healthcare costs, and higher hospitalization rates. Therefore, occupational therapy practitioners should focus on medication management as a therapy intervention. Occupational therapists may choose to use medication organizers, memory aids, along with adaptive devices, and may help to increase compliance with medication schedules. Therapists can combine familiar ADLs with medication management to improve adherence to medication schedules. So you might say, every time you're eating, take your pill or set an alarm on your phone. You will come up with strategies to help your patients based on their different activities. It's important, though, that we determine a patient's deficits and why they're having difficulties with medication compliance and management. So you need to ask questions about, are they having difficulty reading the labels? Are they having difficulty with dosing instructions? Or are they having trouble manipulating or opening the packages? Are they do they not have the fine motor coordination to draw the medication into the syringes? Do they not have the strength to use this pill splitter? Or can they just not even manipulate the pill in their hand to be able to bring it to their mouth? Interventions may include the implementation of adaptive aids such as large print instructions, prescription bottle magnifiers, non-slip bottle cap openers, pill splitters or crushers, bottle grippers, magnifiers, partitioned containers, or medication management kits, watches or alarms to provide an auto reminder of medication schedules. So as you can see, we have a vast role in helping these patients, and we're uniquely placed in this role because we can help them put it into their daily lives rather than just giving them education on the management strategies and how to take the pills. We can help them apply it to their daily life and make it where it's most convenient and set them up for success with taking medications. So I just wanted to say thank you so much for a great semester. It was such a pleasure teaching you guys. I really enjoyed it. Feel free to send me an email if you have any questions now until forever. I would love to hear from you, would love to hear how the program's going, and hopefully I'll get to see you guys again soon as you continue on your program. Lastly, be sure to make sure you're checking the gradebook, as I've been writing a lot of comments on your assignments, and I'm really looking forward to seeing your final project. Please don't hesitate to reach out. Thanks so much. Have a good one.